we're going to be talking today about cannabis and opioid use disorder assessment. And so this is a topic that I'm really passionate about, and especially passionate about the services that we provide to people with cannabis and opioid use disorders and other substance use disorders within various systems that we have. So I know this training is focused on the child welfare workforce, but also many of you probably work with medical providers, with criminal justice providers, with housing providers. And so this is kind of a general introduction over the next hour into the assessment of cannabis and opioid use disorders, and we'll go ahead. So I will also say that if people have questions, if you would be so kind as to add them to the chat, and I will make real sure to have 5 minutes at the end that we can answer questions, and we'll actually turn off the the recording for that, just so that you can ask any other questions that come up for you. So at first I want to talk just about, I can't help myself but to talk about co-occurring disorders. And when I'm talking about co-occurring disorders, I'm talking about people who have a mental health condition and also a substance use disorder at some point in their lives. So when people have a mental illness, primarily a mood disorder like depression, major depressive disorder, bipolar disorder, or a thought disorder like schizophrenia or schizoaffective disorder, or a psychotic disorder not otherwise specified, they have a much higher risk of having a co-occurring substance use disorder at some point in their lives. Over 50% of people with serious mental illness will experience a substance use disorder at some point in their lives. And that's compared to 16% of the general population that experience a substance use disorder at some point in their lives. And the more severe the mental health condition, the greater the likelihood of a co-occurring substance use disorder. The reverse is also true. The more severe the substance use disorder, the more likely it is that people will experience a mental health condition at some point in their lives. So that's the first thing, is that co-occurring disorders are relatively common. The second kind of like variable that we need to think about with co-occurring disorders is that outcomes for people with co-occurring disorders are far worse than for people with single disorders, either single substance use disorders or single mental health conditions. And those are in all of the areas that we care about. So rates of incarceration are higher, rates of unemployment are higher, rates of hospitalization, both for physical health as well as for psychiatric health, are higher, rates of homelessness are higher, and then health condition, both chronic diseases as well as infectious diseases, including HIV, hepatitis B and C, as well as COVID, are also higher for people that have co-occurring mental health and substance use disorders. So that's kind of the second thing. We know that co-occurring disorders are common, that the outcomes for co-occurring disorders are worse than for single conditions, and then kind of the kicker is that people with co-occurring disorders have lower rates of treatment engagement than people with single disorders. So if you're in the child welfare system or any of the other systems, our behavioral health system, our medical system, it is harder to engage people with co-occurring disorders, even though they need some of our best care, right? They really need and have every right to demand that we provide them with the services that they need, because they have at least 2, if not many more, chronic health conditions that respond to treatment, but also if left untreated, people can get really sick and can even die of their co-occurring disorders. So that's just a little bit, that's really kind of my passion population, are working with people that have both substance use and mental health conditions. And I know that a substantial percentage of the folks that you work with in the child welfare workforce also have either one or both of those disorders. So as we're talking about the cannabis and opioids specifically, I want to kind of introduce you to these different drugs of abuse, or different drugs that can develop tolerance, that people can become addicted to physiologically or psychologically, and can have and people can basically develop substance use disorders on these drugs. So, and I'll say, like, nobody develops a substance use disorder on penicillin. Nobody develops a substance use disorder for Lasix, for hypertension, because these they have to have some potential for abuse or dependency or tolerance and withdrawal. So let's talk about the first group of drugs of abuse, which are depressants. So if we think about depressants, which include substances like alcohol or ethanol, barbiturates like Quaaludes or Downers, benzodiazepines, many of which are prescribed, like Xanax and Ativan, and then solvents like paint or glue or gasoline, or things that people would huff or inhale. These are all the depressants are things that kind of like bring the general systems of the body, so the heart rate and the respiratory rate and the blood pressure and the like gut processing, they bring all of those down, and the body temperature. Depressants are also the class of drugs of abuse that are associated with the greatest risk of acute withdrawal symptoms, including seizures, delirium tremens, hallucinations, and even death. So when we're talking about people who abuse or who have a substance use disorder for alcohol or downers or paint or benzodiazepines, these are the folks that we are most concerned about and often require medical intervention to assist them with withdrawal, or they can get really sick enough to be in the hospital. Then we have kind of the flip side of those depressants, which are stimulants, which bring up all of the body systems, all of the heart rate and the respiratory rate and the blood pressure and the body temperature, which are stimulants. So it's stuff like cocaine and amphetamines and methamphetamines, as well as methylphenidate or the psychostimulants or the drugs that are prescribed and used for ADHD. So things like Adderall and Ritalin and other substances that are psychostimulants in nature. So the stimulants, so I think with all of these categories, we're talking about some drugs that are like illegal drugs or street drugs, or what we would typically refer to as sometimes like hard drugs, but we're also talking about prescribed medications. And that's, I think, really noteworthy because I want to talk about that in the context of both marijuana as well as opioids, because they've become our new legal drugs like alcohol and nicotine for many, many years have been our legal drugs. And so the way we interact with the folks that we work with around cannabis and opioid use has to be more similar to the way we interact with them about alcohol or about other legal drugs. So I want to talk about the opioids, which includes all of the opioids. So it's everything from morphine that you might get after you're getting out of surgery, to heroin, to codeine, to Percocet, to oxycodone, to hydromorphone, to fentanyl and methadone. So it includes both prescribed opioids as well as opioids that are not prescribed. And then in addition, there's this third category, right? So they are opioids that were prescribed originally, but they're not being taken as prescribed. So they're either being taken by someone that they weren't prescribed to, or they're not being taken in the way or in the amount that they were originally prescribed. Opioids, as probably everyone knows, are one of the most substantial public health issues that we really have in our communities and in specific communities, but throughout the state of Michigan. And one of the things that's most noteworthy about opioids is the death rate associated with opioids. I'll talk about this in a little bit, but opioid overdose is the #1 cause of accidental death for people under the age of 50 in the state of Michigan. So it's really become, it has become a more likely cause of death than car accidents, which has been like the typical most frequent cause of accidental deaths. We'll talk about those. So unlike I talked about, the withdrawal symptoms for depressants can be very severe and can require acute medical intervention. For opioids, it's not so much that people can die of the withdrawal from opioids, but it is so intolerable for many people that they will return to opioids rather than experiencing that kind of extreme pain and malaise and that is present with opioid withdrawal. So that's what, we'll talk about medication for addictions treatment and really the increased number of tools that we have in terms of medicines that we can prescribe to assist people that have opioid use disorders in much the same way that doctors prescribe insulin to assist people that have diabetes because their body is not making appropriate amounts of insulin. So, and then we've got a class of the hallucinogens or psychedelics, which include things like LSD and mescaline and psilocybin. And so these are actually coming back into clinical trials in many areas because they have some therapeutic effects, but they are also considered Schedule 1 drugs, which means that they have supposedly no approved medical usage, even though they are currently in clinical trials at a lot of really impressive medical schools and institutions. And then we have our other are other drugs of abuse, including cannabis or marijuana. So one of the things that's interesting about cannabis or marijuana is that it acts as a depressant in lower doses. It helps to decrease those bodily symptoms, but also in higher doses, it also has some hallucinogenic effects. So it is kind of in two of these classes. And then we have stuff like steroids and nicotine. So nicotine is interesting because actually, again, it has some stimulant qualities, and then also some hallucinogen qualities when taken at much higher doses. Caffeine is part stimulant, but again, can have some of these like hallucinogen qualities when taken at very high doses. So that's where we see some of the like plant-based, not opioids, which are originally plant-based, of course, but some of the other like plant-based that have a broader array of effects, in part because of kind of the nature of the production. So I also want to kind of introduce that our schedule of controlled drugs. So these are all prescribed drugs, right? Like, so these are all drugs that the Drug Enforcement Agency and the Food and Drug Administration have decided, like, how closely do we have to control these drugs based on their level of dangerousness and their medical indication. So at Schedule 1, we've got things like heroin and LSD and marijuana. And I want to talk about Schedule 1 is considered that it has the highest potential of abuse and dependence, and also that the federal government has decided that there is no current medical indication, that there is no reason why anyone should take heroin, LSD, marijuana. PCP is also a Schedule 1 drug, all of those, because it doesn't have any medical indication. That is mostly a political decision because there actually are some medical indications and there are some therapeutic indications for both marijuana and LSD, but very few, and actually them being Schedule 1 drugs has meant that they weren't studied in clinical trials as much. So that's also why, even though the state of Michigan has legalized marijuana not only for medical use but also for recreational use for adults over the age of 21, why you don't get marijuana at the pharmacy, why you get it from a dispensary. And why back when we had like medical marijuana, like it would be like, oh, pay $200 and go to the Holiday Inn Express ballroom, and you'll see a physician, and the physician will like write you your card for marijuana, was because it couldn't actually be prescribed for like marijuana or cannabis, but it could be recommended by a physician, and then you would get it from either a caregiver or a dispensary. So those are the Schedule 1 drugs, and then we've got Schedule 2 drugs, which include like the more potent opioids, also cocaine, which is actually used sometimes. Topical cocaine is used in some facial surgeries with a direct application, so you can get it in some compounding pharmacies or hospital pharmacies, as well as amphetamines, again, including the amphetamines and the psychostimulants that are prescribed for ADHD. So that's why you can't get a prescription for Ritalin that's like a 90-day or 180-day prescription. You can only get a 30-day prescription at once. And also, you typically cannot get a prescription for Ritalin from a mid-level provider, but it has to be a physician. Then we've got Schedule 3 drugs, which include things like codeine, and which are kind of the less potent of the opioids that are on the market. Then we've got Schedule 4 drugs, which include, again, some opioids, as well as most of the benzodiazepines like Valium and Xanax and Ativan. And so that's why they're a little bit more closely regulated. Also noteworthy that whenever you're prescribing any of these medications for human use, and actually also for veterinary use. So I have a 14-year-old dog who is prescribed gabapentin and trazodone. Trazodone is a Schedule 5, gabapentin is a Schedule 4 drug. And so, I need to like show them my driver's license when I pick up his medicines from our veterinarian, and they run maps to make sure that I'm not like picking up also prescriptions of gabapentin and trazodone all over town or all over the state. So that's kind of noteworthy as well. And then we've got stuff on Schedule 4, which include things like Seroquel, also Lomotil, which is actually an antidiarrheal. And one of the side effects of opioids is that it's a constipating agent because it slows down, again, all of that like gut gut tract productivity. So Lamotil is, has kind of a teeny bit of opioids in it, and that's why it's used as an antidiarrheal. Okay, so cannabis as a legal substance in the US is definitely here to stay. And you can see here from the Pew Research Center that 2/3 of Americans feel as though cannabis should be legal. In 2019, that's only increased. The majority of the states have voted to legalize cannabis for medical or recreational use. So actually 33 states plus the District of Columbia have all legalized some uses of marijuana, including and about 20 of those is just medical use. The other 13 plus DC have approved for not only medical use but also recreational use. And of course we recall several years ago that Colorado was really kind of leading the way and it was become kind of a destination for people that wanted to do like cannabis tourism or wanted to go to, I mean, there were all these like vacation packages that people would do like, oh, come to Colorado or then Washington and California and Alaska. And we were part of kind of that third wave of states that the voters approved. Now I will say, because cannabis is still, again, a Schedule I controlled substance, the federal government still does not recognize cannabis as a legal drug or a drug that has medicinal uses, even though it's being used medically and recreationally in the majority of states. But they've also made it clear that they're not going to spend a lot of time and energy doing interdiction or doing enforcement with cannabis. So marijuana has two different substances in it, basically CBD, cannabidiol, and then THC, tetrahydrocannabinol. So THC is more common in the original plant that marijuana is grown from, which is hemp. So hemp has a lot of CBD, and it doesn't really cause you to feel that high. It's not the psychoactive part of marijuana, although it is associated with kind of like feelings of well-being. And a lot of people are taking, CBD products are really ubiquitous. So a lot of people are taking CBD products for arthritis, for Crohn's disease, for MS. And there are over 150 trials that are ongoing involving CBD that are either actively engaged or are recruiting participants. THC, which is found in marijuana, which is kind of like much more THC than in hemp, and that THC is a psychoactive compound in marijuana. So it's what makes people feel high. It's what makes people feel euphoric and kind of like a little zoned out and a little amotivated and a little calm. So it binds with multiple receptors in the brain. So this is why like it's really like in more than one class of potential drugs of abuse. So in receptors that are associated with pain, that are associated with mood, that are associated with satiety or hunger. And that's why like
yeah, I'll try again. Is she gonna get counseling outside
Sarah,
of school?
I'm gonna go ahead and mute you. There. Okay. Yep. So sorry about that. Sarah, I didn't want to get too much. Yep. You're good. So that's why people feel that like kind of like general euphoria when they're using THC. And so another note about marijuana is that as more states have legalized marijuana and as there's been more progress in terms of hybridizing and really kind of like getting higher content of THC, like the marijuana that you get, whether it's in whatever formation at a dispensary, has typically much higher THC rates and much higher THC concentration than the marijuana that was available 20, 30, 50 years ago. So it's kind of like it's functionally not the same marijuana that people were smoking at Woodstock, right? Like it's become a much more potent product in its current formations. And that's whether you're getting it from a dispensary or even like marijuana that's commonly available. Rutgers University has done studies where they like purchase marijuana from kind of like street level dealers for years and years and years. And they've shown that the THC content or the potency has really increased substantially by about 150% over the last 40 years. So there's some evidence that THC has some medical uses. So that was why I was talking about that it's kind of a political issue that marijuana is a Schedule I drug. It is associated with appetite loss and then kind of the wasting syndrome. Typically, when people are receiving end of life care, if they have cancer, if they have AIDS, if they have other like wasting diseases, that it can help to manage nausea and also increase appetite. It's also indicated for some forms of epilepsy, specifically some forms of childhood epilepsy, as well as glaucoma, which is that because it decreases ocular pressure. Multiple sclerosis, specifically the spasticity related to multiple sclerosis. So when people have spasticity, when their limbs will get spastic, so we'll have times where they're kind of drawn in, or where they feel kind of like hard or rigid. So with some of those muscle spasms with MS. And then again, some forms of seizure and nausea. So those are some of the things that it's approved for. I actually had a 17-year-old client that I was working with this was before recreational marijuana, when it was just medical marijuana. And he was saying like, oh, I'm going to talk to the doctor or psychiatrist in our practice about, will she write me for medical marijuana? And I said, well, you can certainly ask her, but it's not indicated for anxiety, and it's also not indicated for pediatric use. And he was still 17. And he said, well, if she says no originally, I'm going to ask her that I want to put the coma in my glaucoma treatment. Now, of course, he did not have glaucoma at 17 years old, but I did think like, well, that's a clever turn of phrase that you're able to do that. Um, and uh, and he did not get approved for medical marijuana, from at least from our psychiatrist. So some other facts from the Centers for Disease Control about marijuana. It's the most commonly used federally illegal drug in the US. So just under 50 million people, about 18% of Americans, used it at least once in 2019. That rate has only increased. That 3 in 10 people who use marijuana have a cannabis use or a marijuana use disorder. And that the younger you start to use marijuana, the greater that risk, right? So I think with all drugs of abuse, of potential abuse, one of the important messages as all of us in the field is that if you wait to have your onset of using a particular drug, you lower your risk. So that is also true for alcohol, for instance. Even amongst people who have a parent that has an alcohol use disorder. So if you have a parent that has an alcohol use disorder and you start using alcohol yourself before the age of 14, the risk that you will develop an alcohol use disorder is like above 50%. It's also above 50. It's also around 30% if you don't have a parent with an alcohol use disorder, but you still start using alcohol before the age of 14. So the risks are still high, but they're kind of unacceptably high for people who have a first generation relative. If you wait until you're 18 to begin your onset of using alcohol, then even if you have a parent with or you have a parent with an alcohol use disorder, your rate drops below people who started to use earlier that don't have a parent or don't have a family history. So I think that one of the messages that I try and give a lot of the teens and young people that I work with is just wait. Just give your brain a little bit longer to mature, and also that lowers your risk of developing a lifetime substance use disorder. So it really is impactful. So marijuana use affects the brain. So it affects specifically the parts of the brain that are responsible for memory and learning and attention and decision making and reaction time. So that's why you're not supposed to use marijuana when you're driving or when you're operating heavy machinery. You probably shouldn't use marijuana before you go to class or before you go to work in the day, because of that impact on learning and attention and decision making. And it also lowers the psychosis threshold. So marijuana is particularly risky for people who have an underlying psychotic disorder, like people with schizophrenia, or also people for whom, for whatever reason, like their hallucination or their psychosis threshold is lower. So I include myself as one of those people whose psychosis threshold is lower. When I was growing up, when I would have a fever, I would have auditory and tactile hallucinations, that I would like see things and feel like I could feel things. And actually my mom called it fast thinking, that I would have fast thinking and I would have to kind of go through this process of of, getting myself calm and doing mindfulness or doing progressive relaxation exercises so that I could kind of like get myself more calm. And there was a period of time when my mom was worried that maybe I was going to develop a psychotic disorder in my teens or in my adulthood. I did not develop a psychotic disorder, but that's one of the reasons for me that because I have a lower threshold for psychosis, clearly, and I've also got a family history of a serious mental illness, that I've said like, oh gosh, long-term or frequent, or even from my part, occasional marijuana use, because I feel like the risks are too high for me. Also, using marijuana during pregnancy can increase the risk for pregnancy and complications related to that. And so pregnant individuals and individuals who are breast or chest feeding should avoid marijuana use. All right, so let's talk about the first part of our assessment, which is, again, whenever you're talking to people that you're working with who are using marijuana or using opioids, and maybe you're not sure whether they have a marijuana use disorder, but you have some concerns about that, or whether they have an opioid use disorder, there are kind of two sorts of assessments that we want to talk about. One of them is what we call a contextual assessment, which is basically you want to get an idea of like what was a recent day, and let's go through it in detail. So I might say like, let's talk about yesterday. What time did you wake up? And then what happened? And then what happened? And so what we're trying to do is first we're getting an idea of what are people's use patterns like. Now, and say this, like I realize that people have a lot of good reasons why they're not going to be straightforward with us about their use patterns, right? Like there's a lot of, I mean, basically if they're involved in child welfare or law enforcement or an employment related referral, they're afraid that they're going to get in trouble if they're honest about what their use patterns are. So I do think, and this is not to judge people or to say that people are like lying or being reasonable. I think it is actually a reasonable thing to assume that people have very good reasons for not being entirely upfront about their use patterns. The other thing is that some people are using different substances. They're just not very good historians. They're not tracking how many substances they use. And I'll use an example of this with alcohol. Usually when you ask people like how many drinks did you have, typically people refer to anything that any amount of liquid will fit into as one drink. So that can be a 12-ounce can of beer, or it can be, a big gulp from Speedway that has, 40 ounces in it. And whether that's filled with vodka or water, people usually talk about that as like one drink. So one of the things that we want to keep in mind is when we're talking about cannabis and opioids, are what are kind of the doses? What is one serving of marijuana? Like we know one serving of beer is 12 ounces. It's like a can of Coors Light. One serving of hard liquor is 1.5 to 2 ounces, right? Or a shot of liquor. So, if I have my little hydro flask, which I think is 16 ounces, filled with vodka, then I have like um, then I have between 8 and 12 servings of vodka in this one thing. So it's not one drink. It's really 8 to 12 servings. Similarly with marijuana, right? Like there is a difference between like someone who's smoking some skinny little weeds and seeds joint and someone that's like smoking like 3 bowls of super high quality marijuana. Or there's a difference between someone who's taking Lamodal, which has like, kind of a baby aspirin dose of opioids in it, or someone who's taking what they think is oxycodone that they bought off the street, but may in fact be fentanyl, powdered fentanyl that somebody's put through a pill presser. And so like that's the other thing that I can, when I'm talking to people who are using really more opioids than marijuana at this point. Although, people can put stuff in marijuana too that's not good for you and that you may not choose to take. But when they're taking opioids, like you basically have to trust the word of someone who's willing to sell you drugs, that they're selling you like what they think they're selling you. That even, heroin is certainly laced with fentanyl, but even pill opioids are often have fentanyl on them, and that's really where the risk of overdose and death gets very high. So when we're talking about this contextual assessment, we want to talk to people about what kind of doses are they taking, but also what comes before and what comes after. Because oftentimes when people say like, oh, well, I end up high and I don't really know how I got there. In the same way that people say like, oh, well, I was just in the middle of a panic attack. Well, what do you think caused your panic attack? Nothing caused it. And it's like, what caused it. But we do need people to help connecting the dots. Like, oh, when I have a conversation with my aunt who super stresses me out, or when, I know like my protective services worker is going to come over, like I get really anxious about that. Like that's the precursor to the panic attack, or that's obviously like there are things that come before, and then there are also responses to when people are having are kind of in the middle of being high, like it's like, oh, I'm in the middle of a temper tantrum and I have no idea where it came from. It's like, well, we need to like track that back. So that's about people connecting the dots for the day. You can also do a longitudinal assessment, right? Like it's kind of like your life in a timeline, like you do in second grade, right? Like that you say like, oh, so I might say to somebody that I'm working with, let's take a kind of the red pen. When was, and if the start of the timeline is the day you were born and the end of the timeline is today, what's the first time that you remember having any like mental health symptoms? Or what's the first time that you remember ever using alcohol or marijuana or opioids or all these different things? And let's talk about the times when that was going better and the times when that was going worse in your life. And we'll kind of have above the line, below the line. And sometimes it's really striking how we can see these trends. Like when I'm feeling more depressed, I or or when I'm having a harder time with family stressors, I tend to use more opioids, or I tend to drink more, or when I drink more, I tend to feel more depressed, or I tend to sleep more, or just not want to be as involved. So I think we can do that a number of different ways. Sometimes when you can like put it down on a piece of notebook paper, it's so clear to both of you that are talking about it, and that can be really powerful. So again, we're helping people to connect the dots between these trends that exist in their lives, because oftentimes people think there's no relationship. Like there's no relationship between my mental health and my substance use, or there's no relationship between my substance use and my physical health, or there's no relationship between my substance use and kind of how engaged I am as a parent. And so we're helping people to connect those dots to help them move along in stage of readiness. So I want to talk a little bit about like motivational interventions and how we need to use those in our assessments. And so I just want you to think for a second about the times when either someone has tried to convince you or persuade you, or you've tried to convince somebody else to make one of these changes, to change your exercise, to change your diet, to quit smoking. And so if you think about like the people who've maybe tried to persuade you to do some of these things, or to move, or to handle problems with your pets in a certain way, that there's approaches that make you more ready, that are supportive, non-judgmental, listening. Sometimes it's someone who's doing the change with you, who recognizes how demanding it is and how hard it is. And then there are other times where the approach is something that just makes you more resistant. Like, so, when people are coming at me, trying to persuade me to make one of these changes, and I tend to be really a resistant person. So I can easily, if I feel like someone's trying to boss me around, and we even like in our family, we call this like bossy, you're being such a bossy cat. You're a bossy cat. So if somebody's trying to be a bossy cat with me, like I will be super resistant. I will do things even that I know are not going to serve me well. Like they're not going to be good for me, but I'll do them anyway just to prove like, oh, I can make these decisions on my own. I'm a grown person. I can do this. So there are times when, and I think many of the folks that we work with are similar, right? Like based upon our approach when we're trying to persuade people to live a healthier life, because we want the best for them. But also, if they feel controlled, if they feel judged, if they feel like you're bossy catting them, then sometimes the reaction is the opposite, even if it's something that like is not helping somebody. And they know it. Like if like, oh, well, if you continue to test positive for marijuana, you're not going to get parenting time with your kids. And sometimes people will be like, oh, why does the government have a role in my life? And you're like, yeah, I hear you. And yet that's where we're at. Like, it's kind of like radical acceptance. Like we kind of accept like this is where we're at. At this point, the government is kind of like up in your business. And I know that does not feel good. Um, so, and also, um, do we do all of these things that are also good for us? So I'd like for each of you to think about just in your own mind with these 5 things, how many points would you give yourself? 1 point for, do you always use your seatbelt? even when you're in the back seat? 1.4, do you always wear sunscreen, even on cloudy days, even on rainy, or even like, I dare say it, sleety days in Michigan? Always eat at least 3 servings of vegetables a day. Do you floss your teeth every day? Do you always abstain from using your cell phone while driving? No texting, no phone calls, no entering GPS information. I would give myself 2 points. Like, I don't know if anybody else, maybe some people would give themselves all 5 points. I would think that would be a rare person, right? Like, and we know that all of these things are good for us, right? So like, even as educated, employed, privileged people, we don't do all of these other things and motivational interviewing or motivational approaches recognizes that we're ambivalent about doing even some of the things that we know we should do, right? Like, so it's easy to become stuck in that sense of ambivalence, or it's easy to become like, oh, like I don't like to use my cell phone, but if I'm using it hands-free, that doesn't count. Or, I'm probably at low risk for developing skin cancer because I live in Michigan, or, all of those things. So, we have this way of rationalizing with things. So when we're talking about marijuana and opioids, I want you to think about when people are ambivalent. I mean, if people are involved in the child welfare system and they use marijuana, and maybe they have a marijuana use disorder or a cannabis use disorder, then they're probably pretty ambivalent about that. Part of them is saying, like, I don't know why this is anyone's beeswax, what I'm doing in the privacy of my own home. And part of them is saying, like, this doesn't impact my ability to be a good parent. And part of them is saying, like, people are intruding on my life. And all of those things are true. And then there's another part of them that's saying, like, oh, like maybe now that I'm in this kind of jam, I do need to think about my relationship with marijuana, if only because it impacts my ability to be a parent. And maybe I haven't been quite as present as I could have been if I wasn't using marijuana or opioids. And maybe, and I use my opioids to manage my pain, but I also use my opioids because they feel good. And I probably use more than my doctor thinks I'm using, or I've maybe even started supplementing it with a little bit of extra opioids. So there's we're really on that horns of a dilemma. When we're ambivalent, there is part of us that feels one way and part of us that feels another way. And so it can be tempting to want to kind of like push for like positive change, to try and enforce that, to be like, you have to do this because it's the right thing to do, and I want you to be healthy, to either cheerlead or to like kind of like enforce change. Like, if you don't do this, you're going to get in big trouble. But an alternative when we're doing an assessment is an alternative when we're assessing is to recognize that if part of people wants to change and part of people doesn't want to change, then sometimes our approach can be something like, well, I don't know, maybe you don't want to change. Maybe this is not something that you want to be different, to allow people the space to occupy that chair that is in favor of changing, and to argue for their own change for their own reasons and based on their own values. So that can be an important thing, is to kind of like give people space to recognize both of those sides, and also to kind of say, like, well, as we're talking this through, you have some reasons why your opioid use is exactly like you want it to be, even if it's become a disorder. It's exactly what you want. Why would you want to change? And then someone might say, well, if I don't change, I'm not going to get my kids back. Oh, okay, so that's a pretty big deal. And is it important to you to get your kids back? Because it really is. I mean, like 95% of people, every once in a while, people will be kind of ambivalent about even getting their kids back. Which we also have to approach with no judgment, right? So I want to talk about opioids for the next few minutes, and that in 2012, healthcare providers wrote 260 million prescriptions for opioid pain medication. That was enough for every adult in the U.S. to have one bottle of pills. So one of the things we know is that opioids are ubiquitous. Like, there are so many opioids, like in our communities and in our in our purses and in our medicine cabinets, and it is a dangerous drug to just be hanging out there. And part of the reason whenever I'm talking about like, oh gosh, like why is it that we've created this like huge public health issue? And one of the questions that I'll often ask is like, who is benefiting? Who makes money from this? So I think we know with opioids that who makes money from it are the pharmaceutical manufacturers who have been held to account by multiple state attorney generals, by multiple class action suits, and they were making a bunch of money. So that, you know, if you talk about like, well, why were there so many opioids on the market? Because they were marketed inaccurately to physicians, and the pharmaceutical companies said these can be prescribed for low to moderate pain, and they have almost no risk of developing dependency or addiction, which was not true. And they also said that, you know, with oxycodone, that, well, you couldn't misuse oxycodone because it has this like layer on it that allows for like a constant distribution of the medication over 12 months or 12 hours, excuse me, not 12 months, 12 hours. But they found out like very quickly when oxycodone was first out in the 90s that all you had to do was like suck off or rub off or dissolve off that coating, and then you could take it and get all of it at once. Right. So you would get all the dose of an oxycodone tablet, or you could smoke it or huff it or inject it or whatever to get the full dose all at once, which of course is super incentivizing, really activates all of those opioid receptors in our brain, has that analgesic effect where not just that you're experiencing euphoria, and it's not that you're not experiencing pain, it's just that you kind of like don't mind that you're experiencing pain because you're so euphoric. And also keep in mind, like, our body produces natural opioids for a reason, so that if we're injured, that we can still get away from something that's trying to get us and eat us, right? So that's why, like, if you're running a distance race, if people that are running a marathon that have a stress fracture or pull a muscle during during the marathon, and they don't realize it until like the next day because they've got a lot of opioids kind of running through their system. People that are injured in combat, sometimes even people that are shot in situations, don't realize that they've been shot until minutes or hours later because they've got so many of those opioids running through their system that are managing that pain so that they can get away from that dangerous situation. So opioids are a really effective evolutionary way of keeping us alive when we're in dangerous or pain-based situations. So the pharmaceutical manufacturers knew very well what they were doing, are being called to account on this, and we're also making a bunch of money. So we talked about in the US, we want to talk about Michigan specifically, that there were 11 million prescriptions for opioids written in 2019. There's only 9 million residents. So in Michigan, it's even worse than in the nation. There are more than one bottle of opioids for every individual, every 8-month-old, every 80-year-old in the state of Michigan. In 2017, there were 1,600 specifically opioid overdose deaths. It's the #1 cause of death in the state of Michigan for people under the age of 50. We've got some special populations of concern for women who are more likely to present with chronic pain issues and also more likely to be prescribed pain medication in higher doses and to use for longer. And also that relates to neonatal abstinence syndrome, or babies that are born with opioids in their system, which I know all of you are aware of because it's a major focus of child welfare. Every 25 minutes, a baby's born that is suffering from opioid withdrawal. And I want to say something that's maybe a little controversial here. Opioid withdrawal is not medically complex. Like, there are no babies going to their pediatrician saying like, I would like another prescription of opioid, you know, like demanding opioids. So, so one of the keys, but it has impacts on hospital stays, and has impacts on costs, it has impacts on has potential impacts on opioid use risk amongst the infants themselves as they grow older. One of the primary ways that we can address this is through prevention, which means that we need to do standardized drug testing for women that are pregnant, not just some women who are pregnant, not just Black women who are pregnant, not just women who have Medicaid that are pregnant, but if it is a standard of care that if you have a substance use disorder during your pregnancy, then that is a prime time for motivation, for treatment, for early interventions to prevent a baby from being born with opioid use disorder. So that if that is part of the standard of care, then that is what we need to do. And that also means that we need to make the resources available so that pregnant women feel like they can come to their healthcare providers and seek out treatment, so that they can prevent having a baby that has to go through neonatal abstinence syndrome, which is just, I mean, it is an avoidable outcome. And one of the things that we really struggle with is we've got so many things in place that keep down the treatment seeking, right? That keep pregnant individuals from saying that they have a substance use disorder, or saying that they're concerned, or saying that they need treatment. So so I think, you know, we gotta make sure that we're thinking about what are we incentivizing, and then what are we disincentivizing. I also get really concerned about teens, right? In 2015, OxyContin was approved for 11 to 15-year-olds, for use in 11 to 15-year-olds. And that's resulted in an increase in overdose deaths for young people and for teens nationwide of just under 20%. Okay. One of the things that we can do to help assess for opioids, as well as to help intervene with opioids, is to really think about all of the things that are in that class of opioids. So the class of dogs contains Springer Spaniels and Cocker Spaniels and Dachshunds and Basset Hounds and Pit Bulls and German Shepherds. So these are all varieties of things that are called dogs. Opiates is the general category, but then there are all of these things that either the trade name or the scientific name, or sometimes the street name, is called something else, but they're all opioids. So Duragesic and Fentura and Lorcet and Lortab and Norco and Vicodin and Dilaudid and Demerol and Methadose and MS-Cotton and Oxycontin and Percocet and Roxacet and oxycodone and naloxone are all opioids. So we certainly want to make sure that people are aware that if, you know, well, I got Demerol from one doctor and then I got Vicodin and Lorcet from another doctor, that you need to be really careful that you don't take all three of those things at the same time, because you could accidentally overdose on them. And that's particularly an issue for older adults. Like a lot of times when we're doing stuff with adult protective services, that's something that we really need to think about to make sure that people are aware of what they're taking, and that their healthcare providers are aware as well. So, you know, sometimes people will say like, oh, who would use heroin? Oh my gosh, who would use heroin? Nobody starts with heroin. I want to be real clear. Like, no one starts using, no one, like, you know, goes home. None of you are going to go home from work, nor am I going to go home from work and be like, whoo, gosh, I had this webinar in the middle of the day. I really like it. It's a topic that I really enjoy talking about. I'm a good educator about this, but I'm really worn out. I think I would buy some heroin and shoot up with heroin on my way home. Nobody does that. So past misuse of prescribed opioids is the highest risk factor for heroin use. So what happens is that people start to use opioids, and then they start to use more and more opioids. So they develop a tolerance for opioids. They need more and more to get the same effect. And before too long, it starts to get away from them, right? Like a lot of times people have even started to use, they had a valid prescription to begin with, and then it just kind of got ahead of them. They started needing a little bit more and a little bit more. Before too long, they were out of their prescription. They needed to get it someplace else. They maybe got it from a friend, got it, you know, took it out of somebody's medicine cabinet, got it from their grandma, and then they're buying it on the streets. And then before too long, you're taking 20 or 30 or 40 tabs of Vicodin a day, or what you hope is Vicodin. Again, you know, we don't know, right? And then heroin is just cheaper and easier to get a hold of. So so that's how heroin starts. A lot of people, heroin can be used in multiple methods. A lot of people start with snorting heroin or smoking heroin and then move on to injection. 1 out of 250 people in the US reported using heroin in the last year. I mean, that's real. Heroin is experiencing quite the renaissance. You know, I mean, it was real popular in the 70s and 80s, but now it's regained popularity again. So when heroin increases, deaths by overdose increase. And about 5 deaths for every 100,000 Americans in 2016. Michigan is the 5th highest state in terms of opioid overdose related deaths. And heroin related deaths have increased fivefold. So if we see like all opioid related deaths, sometimes like that has gone up for a while, but then we see like more people are moving over to heroin. So then that goes up, and then more people are converting over to fentanyl, using fentanyl either accidentally or on purpose. So it's really like heroin and fentanyl are kind of driving the opioid overdose deaths at this point in many communities. It's not just that people are dying of opioid overdose deaths, but which people are dying of opioid overdose deaths. And males of working age, specifically white males of working age, have some of the highest death rates from opioid overdose. So I am glad that we are all recognizing that opioid use disorders are a public health crisis in the US. I also feel like sometimes when I see it on the news and I think like, okay, we treated crack cocaine in a very different way. We treated that as a problem of criminal justice and a problem, and we see all these like racist tropes and gender biased tropes kind of playing in the background of, the crack hoes who will sell their babies for a rock of crack and all of this. We need to like lock them all up so that was a way to increase mass incarceration, typically in Black and Brown, Black, Latinx, and Indigenous communities in urban areas. And so it's a very different population that has the highest risk of overdose death. And so as I think about that from a public policy standpoint, it also bespeaks the nature of our policies in our nation that we're willing to treat opioid use disorders as a public health issue, which it is. It absolutely is. But we were unwilling to treat cocaine use disorders as a public health issue, which was also a public health issue for those that were impacted. So assessment and education for people that are experiencing pain, and you may be kind of concerned about them, like, hey, is their opioid use disorder kind of getting ahead of them or getting away from them? Understanding the medications, opioids, labeling them appropriately, discuss how to use medications responsibly. This means like you don't keep it in your medicine cabinet. You keep it someplace else. You keep it in a locked box. You keep it someplace that, of course, your kids or anyone who uses your bathroom cannot get access to. So don't keep it, in a bottle in your medicine cabinet. Also, don't keep it in your underwear drawer because that's the second place that people look, right? So you need to have, if you have scheduled drugs in your home, you need to have them in a lockbox so that nobody gets a hold of them who's not supposed to. You also, once you're done using opioid medication or any other controlled medication, you need to dispose of it. So take it to a pharmacy, take it to one of the drop boxes that are at police stations, take it to a drug drop off or drug take back site so that it is not sitting there. Do not flush it down the toilet because then it just ends up in the water system. We need to talk to people about pain and like non-pharmaceutical interventions. Opioids are not very effective at managing chronic pain. And the risks are very high. So we're, none of us are prescribers here. So I would think we're in the business of cognitive behavioral interventions and mindfulness and case management and community support interventions, and really to teach people to be partners in their own healthcare, to talk to their healthcare providers in a very open and honest way about what they need and also what's going on with them. So I want to talk about assessment of overdoses just for a couple of minutes, and then we'll leave a couple of minutes for. So when people are overdosing of opioids, it's because they stop breathing. I mean, their heart stops eventually, but that's how. So when we're recognizing an overdose, it's people that are non-responsive, that have a blue tinge, shallow, slow, irregular breathing. And the first thing we want to do is prevent opioid overdose, right? So even if people have an opioid use disorder, we want to make sure that they don't overdose, which means four things. To be aware of four things in terms of harm reduction. Don't mix opioids with anything else. If you're using opioids, just use opioids. Beware of times when you have low tolerance. If you've been in jail, if you've been visiting grandma, if you've been in the hospital, your tolerance is likely lower. So you might need to take a smaller dose of opioids because you can always take more, but you can't take less once it's in your system. Beware of the quality of the opioids that you're getting. Like, use a consistent source. If you get it from somebody, get it from that same person. Don't just get it from like any random person. And then also use with a buddy. So don't use alone. And then I would say finally, like, have a Narcan kit that's available. This is the Scare Me mnemonic. Hopefully most of you have access to a Narcan kit that you carry with you. I have one in my car and I have one in my office. But the Scare Me is you do stimulation, like a good stiff shake by the shoulders, not a like, hey, hey, are you okay? I really like take somebody by the shoulders or that sternal rub. Take your knuckles, kind of rub it on the breastbone in the middle of people's ribs. If they're not responsive, call 911. Secure the airway, start rescue breathing, and then evaluate. If you do have a Narcan dose available, if they're still not breathing after you start rescue breathing and evaluate, then that's the time to introduce either a nasal spray, a mucosal, or a muscular like an EpiPen of Narcan. Keep in mind, if people are able to arouse if they've had Narcan, you just saved their life, which is wonderful. They're not going to be happy about it because they are going to be experiencing precipitated withdrawal. So administering Narcan just gives a second for the first responders to get there because they're probably going to need more doses of Narcan in the emergency room and in the ambulance. So I want to kind of like end with this opioid risk tool, which is available just like on a Google search, an opioid risk tool, as you're talking to people about their opioid risk, to keep in mind that if you've got a family history of substance use, if you've got a personal history of different substance use disorders, if you're middle-aged, if you have a history of pre-adolescent sexual abuse, you'll notice that this says 3 for females and 0 for males. I think this has got to be an underreporting issue, right? Like, because certainly the risk that pre-adolescent exposure to trauma, especially sexual abuse, for males is also a risk factor, but males are less likely to report sexual abuse because some of our homophobia and transphobia that we have in our communities. Also, if you have a co-occurring psychological illness, then that increases your risk. So as you're talking to people who are using opioids regularly, perhaps even as prescribed, or perhaps they're using opioids recreationally, to keep in mind that it's important that they know that like some people have higher risks for their opioids getting away from them, for beginning to abuse opioids. And so the higher your score, obviously the higher your risk, and the more conservative you might need to be about your opioid risk. Um, so this is, I'll just like leave this with you. So this is when we're talking about, it's like talking about those 2 chairs, right? So sometimes when I'm introducing this concept of an assessment with cannabis or opioids, I'll talk to people about like, what are the good things about your current opioid use? How is it helping you? How is it benefiting you? What are the pros? What are the not so good things about your current opioid use? And then what would be the good things about decreasing your opioid use, decreasing your marijuana use? What would be the not so good things about that? And sometimes like letting people kind of sit with these 4 quadrants for a little bit, because ultimately like it is their decision. We are helping people with the process of change in their own lives. We really can't probably enforce that. So we want people to understand what the pluses and the minuses are of either decisions or multiple decisions that they can make.